Hello, I'm Dr. Maury Markman from City of Hope, and I'd like to briefly over the next couple of segments talk about the topic of precision cancer medicine, one that's obviously very important and is only evolving and very rapidly. So in this particular segment, I'm going to talk a little bit about the past. Next segment, the present, and finally, the future. The past. Well, precision cancer medicine didn't just start recently. In fact, you can go back and say it was the original form of anti-cancer treatment. And what I mean by that, of course, is observations in women with breast cancer, that it was noted that in the premenopausal state, removal of the ovaries, which even in some circumstances might be done today, but that was an anti-cancer therapy to surgically remove the ovaries, and there was short-term regression of the breast cancer, a metastatic breast cancer, or locally advanced breast cancer. That happened many, many decades ago, actually, much even longer than that. Removal of the testicles. We didn't even know that was called testosterone at the time, was a form of treatment for metastatic prostate cancer. So again, precision cancer medicine is not a new concept. What, of course, happened, of course, is we began to understand. We understood about estrogen. We understood about estrogen receptors, progesterone receptors, androgen receptors, and that became an incredibly important form of therapy. And of course, those therapies were, in fact, widely used. But that was pretty much it. And we certainly did not understand the gene or genes, and certainly the concept of genetic abnormalities, whether they were somatic specifically or germline, which of course also translates by definition into the tumor, was not known. So the revolution began, and is continuing today, with the understanding of the molecular biology of the cancers. And we learned really not much more than 20 years ago about the importance of targeting HER2 overexpression as a treatment for metastatic breast cancer, and then, of course, as a treatment in an adjuvant setting, very standard of care. Of course, the world of CML treatment was revolutionized with the understanding of the targeting what is called oncogene addiction, the imatinib for the treatment of BCR-ABL, CML-related, of course, disease, which again has revolutionized the treatment of that illness. And we have a number of other examples going back that length of time where the standard of care just completely changed the management of these illnesses. We actually had a number of false starts. The understanding, the assumption that, well, all we need to do is find overexpression of a particular receptor. EGFR is a classic example. We just find all the tumors, and there are many, if not most, where EGFR is overexpressed, and we simply target overexpression. Didn't work. And in fact, billions of dollars were spent by the pharmaceutical industry and academic institutions simply looking at overexpression of EGFR, until we learned it was a particular mutation or mutations that one needed to target, and drugs for those particular abnormalities. That changed those illnesses. So much has happened over this period of time, leading us up to what I would say is the present. And we're going to discuss that briefly in our next segment. And I thank you for your attention.